Perfect. Okay. Hey, Dr. Eller, and we just finished a lab on ribs, and some of it's kind of confusing, so I'm just going through some highlights for some structural rib diagnoses. So you have the anterior rib where everything has kind of turned and shifted forward. A posterior rib where it's done the opposite way, the rib's rotated posteriorly. You have an AP compression rib, which there's been some sort of trauma, some external force that has, like a bear hug squeeze is a common reason for the anterior posterior aspect of the rib to go in, causing the lateral rib shaft to go out, kind of maybe exaggerating like a bucket handle, if you will. And then the lateral compressed rib is an external force into the lateral aspect of the rib, causing the anterior posterior insertion sites to come out. Okay, so those are your 4 structural rib diagnoses. And I'm going to demo on somebody just to show everybody how the treatment looks. But I wrote down on here, like, what is the patient's force and what is your force, okay? So the big difference between an anterior and posterior rib for the doctor is which side of the rib angle are you going to be on and what way are you pushing. So to make that easier for y'all, I made a rib. So I'm going to come on this side. So let's pretend this is our Sam Houston State University rib here, right? And if we have an anterior structural rib, subluxed rib, what's happening? It's actually kind of rotating this way, okay? And so our force as the doctor will be to be on the medial side of this rib angle, pushing out laterally to help guide it back into place. And then for a posterior subluxation, the rib will actually be kind of rotating this way. Therefore, we get on the lateral aspect of the rib angle and we traction medially. Rotate that back while the patient is using their forces to use the muscles to pull the rib forward. So everybody gets confused as far as what directions the patient should move. I have a nice simple analogy, story. I like using stories because you'll remember them easier. So I think of, we'll pretend my arm is a rib, okay? And I think of the anterior posterior ribs of a battlefield story, and the rib is the soldier, right? So if you have an anterior rib, it's going to be forward. And let's say you're at the front line of the battlefield, so you're in the anterior line of the battlefield. You need to retreat and go back. If you have your shield, what are you going to do with it? You will drop it, right? So you will either go down or you'll throw it out. So the patient's motion is down or lateral, whichever one you decide to use, right? And then if the patient is lateral, that's also the force that you're doing on the posterior aspect behind on the rib. So the lateralities, whatever the patient's doing in the front, is also what you're doing in the back. Now, if you have a posterior rib, so you're in the back of the line, the back of the battlefield, and you need to come to the front line, what are you going to do? You're going to actually bring your shield up, right? So that's the motion of the bringing a posterior rib anterior. The arm will go up for the patient, or it will go in, right? So I'm going to use my patient here. Yes, thank you so much. I'll just have you sit right here facing that way. So we'll pretend that he has a dysfunctional anterior rib in the front on the right here, number 3. So you take the arm of the same side that's dysfunctional and just grab the other shoulder and you'll stay like that. I will be behind the patient on the other side and contacting the rib angle, okay? So if it's anterior, I need to engage to the point where I feel motion back here with the rib head. And then I feel it right there. And so what are we doing? We're trying to make it go posterior, so that's where we drop the shield. So the patient will either push down or they'll push out, and I just resist. At the same time, I am pushing out laterally. So I'm on the medial side of the rib angle, and I can use my thenar eminence, my thumb, whatever you'd like to use, whatever feels best, but I'm using a lateral force, okay? So the whole treatment would look something like this. Push down, 1, 2, 3, relax. Down, 2, 3, relax. Down, 2, 3, relax. Push out, 2, 3, relax. Again, 2, 3, relax. One more, 2, 3, relax. And then I would reassess. So if we have a posterior rib and we want to bring it forward, again, I find the rib head. I bring the patient's arm up just like before. I engage till I feel motion. And now it's just the opposite direction. I'll have the patient push up, and I'm pushing from the lateral aspect of the rib angle towards me to the midline. And relax. And I'll do that 3 times. 2, 3, relax. And then I can also have them go medial. 2, 3, relax. 2, 3, relax. Do that 2 to 3 times at least, and then recheck your findings. So I'll use the dummy first. For the AP compression, right? Make sure I'm calling it the right thing. So for the AP compressed rib, you have that external force where somebody came in and gave you a bear hug, right? And squeezed everything in. Look what happens. Everything comes out laterally, okay? So if I have a rib that's sunk in here in anterior and posterior, I'm gonna find that rib until right here, and I'll sit next to the patient, and I'm gonna make contact with this whole rib, okay? And then I'm going to bring that apex of that rib closer to me, and that will help compress these ribs back out. So what that looks like on a patient, say he has a AP compressed rib over here. I'll put his arm on my shoulder, and I find the whole rib, make contact, and I bring it in towards me. And that's gonna create some side bending to his right, away from me. What he will then do is take a nice deep breath in, and then push with your arm into me like you're trying to side bend towards me, and relax. And then you just bring up the slack and repeat 3 to 5 times. Good. So that's for the AP compressed rib. Now if we have the opposite, if we have that lateral compressed rib, very common in a fall or a football injury, somebody getting tackled to the side. So you can imagine if you're getting a hit here, the anterior and posterior aspect of the rib will then come out, okay? So we need to then make contact and squeeze it back in, and we'll be pulling it towards us to help guide that rib back out, okay? So what that looks like, so let's say we got a laterally compressed rib here. Actually, we'll do it since I'm on this side. We'll make it this side. Perfect. Okay. So make contact with the anterior and posterior aspects of that rib, and you will have to look for it, right? Because it's not going to be the same level front and back, right? Usually the back is a little bit higher than the front. So you might have to play around and follow that rib until you find it, and then you can kind of push back and forth in between your hands, articulating that rib and feeling for motion to make sure you're on the same rib. Once you've established that, you can compress that rib, and so you can use your fingertips if you feel like you have good control, but a lot of times people will use their thenar eminence and get on both aspects of the rib. So I'm on the rib, I'm not on the spinous process or the transverse process or the sternum, I'm on the ribs. I've compressed my hands together, and now I'm guiding my hands towards me. What else will happen? Their arm, again, is on my shoulder, and what is this creating? It's creating a side bending away as I pull towards me, and then he will use his arm and pull down towards the shoulder, creating right side bending. And we'll do that 3 to 5 times. Perfect. And this makes sense too, doing it this way, because there's a lot of attachments. You have serratus anterior coming, you have your pec, you have a lot of muscles that are coming from the humerus and one way or another attaching to the rib cage. So those muscles are also pulling this out laterally, helping your brain come in as you're guiding the bones in. And I hope that was helpful.